This is a case of infected liver cyst. A 52-year-old female was operated for a liver cyst elsewhere, and it was believed to be an infected liver abscess for which only the drainage of that cyst cavity was done. As it was a partial drainage of the cyst, believing it was a liver abscess, patient continued to have that palpable lump, and now because of the infection inside that cyst, she presented to us with pain, lump, and fever. As you can notice in the CT scan, a large cyst with collection of gas. This was the palpable lump this female had. And we planned for an open exploration and a wide deroofing of this infected liver cyst. The right subcostal incision was taken exactly over the size where we could palpate the cyst. Once we went inside the abdomen and we exposed the liver, we could see infected ascites or the reactionary ascites which was there. We aspirated that, and as we started separating the cyst from colon, here the complete cyst got punctured and there was a gross pus collection which was drained out. As you can see, this is a large amount of purulent material which started pouring out from that cyst wall. Once this pus was completely aspirated, we decided to go for a widest possible deroofing of this cyst. We treated it as a symptomatic liver cyst in which widest deroofing possible is done. Now, in view of infection here, we had to debride the cyst cavity completely. The contents which were there, infected muck and the infected solid component of this cyst, was completely removed with hand. There was no hydrated membrane or no evidence of an hydrated cyst in this. The complete solid muck was removed and the cyst cavity was completely cleaned. Once that was done, the de-roofing of the cyst was started. So we started palpating the cyst wall. The edge of cyst wall to the liver was cut using a cautery. So here this is the superior or the superior aspect of the cyst wall which was taken care of. As you can see, we have just hold it in our artery forceps and exactly as the edge of liver and cyst, we have started cutting off and doing a wide de-roofing of the cyst. So once this was done, the inferior aspect of cyst wall was also pulled up and it was cut. Because of the long-standing infection, it had become a thick-walled cyst, and you can notice the pus or the thick flakes around the cyst wall which were there. And all the cyst wall was completely removed and white deroofing was attained. This is the inferior border of the cyst, the white cyst and the red liver exactly at the margin. We started doing the deroofing complete. Now we are coming towards the lateral aspect of the cyst and the complete deroofing was attained. Once this deroofing was done, the cyst cavity was given a copious lavage with normal saline, and after complete wash, we packed the cyst cavity with the Omentum. The hemorrhage or oozing along the cut margin of the cyst was taken care by using PDS or proline 20 suture. A continuous proline 20 sutures were taken along the edge of the deroofing margin so that the bleeding is completely taken care of. Here you can see the complete cyst which is deroofed. We have taken care of sutures, bleeding with the sutures, and now in this cyst cavity, to obliterate it, we took proline 20. The omentum was put as much as possible inside the cyst cavity, and the omentum was tied with the both the cyst wall, the inferior as well as superior, and the omentum was sutured. This is the Omentopexy which was done. A drain was kept next to it, and this patient had an uneventful recovery. At the end, you can see the completely packed omentum inside the liver, and on follow-up imaging, this is